Here to give our medical update is Dr. Dan Bowers.
Thank you, Angela. I would also like to thank the audience for coming to our conference this morning. This is a conference that has been planned for at least the past 9 months now, and it's really exciting for us to put on this conference for you and to give you the latest updates in the medical and psychosocial areas for childhood cancer survivors. Just like Heather and Ara, when they put their talks together, they at the last minute they filtered their talks, and it became apparent that they needed to make some changes in their talks. When I presented this talk to my wife, who serves as my filter most of the time, she said, "Wait a minute. If you look at this talk, you're going to freak out the audience. The audience is going to become panicked. They're going to immediately run to the nearest emergency room to get screened for various different complications." But let me assure you that as I give this medical update, that the purpose of this talk is not to cause you to be afraid. Instead, it is to really to cause you to be informed. And I think knowledge is power. I think knowledge is very, very important for you to understand exactly what the potential medical complications might be. But certainly just because I have something listed on a slide as a possible complication, by no means does that imply that this is something that we expect to happen. And in fact, we know that most childhood cancer survivors are healthy, and we want to give you knowledge so that you can better take care of your own health. So as far as the outline of my talk this morning, first I'll just talk a little bit about childhood cancer survivorship. Then I will give a medical update. I like to give this medical update in the format of some case presentations, tell some stories, and give some examples of childhood cancer survivors and the medical complications that they faced. Hopefully this will connect with you, and you will identify with some of these patients, and will help you be more knowledgeable about the potential side effects. We'll then talk a little bit about fertility after cancer treatment. We will also talk about screening for late effects among childhood cancer survivors, and then go ahead and wrap up. In the United States, every year, there are 13,000 children diagnosed with cancer. Now, every child who's diagnosed with cancer is unique. No two children who are diagnosed with cancer are the same. And likewise, their long-term side effects are going to be different. And so just because I list one long-term side effect doesn't mean that every childhood cancer survivor is going to develop this long-term side effect. But rather, we know that there are certain high-risk populations that are at risk of developing side effects. And again, it's my purpose to inform you, to give you a sense of what your risk might be and whether this is something you need to worry about or if this is something that you do not need to worry about. Fortunately, 80% of children diagnosed with cancer in the United States will be long-term survivors. And in fact, arguably, this is the one fact that allows me to get up and do what I do, taking care of children with cancer. So we know that the majority of children who are diagnosed with cancer will be long-term survivors. That means that there's over 300,000 survivors of childhood cancer in the United States. And actually providing a little bit of an update of our statistics, the most recent statistics I've heard was that 1 out of every 480 young adults is a survivor of childhood cancer. And trying to put that into perspective, if you took, say, Cowboy Stadium and filled it up with young adults between the ages of 20 and 40, there would be over 140 childhood cancer survivors in that audience. There are a lot of childhood cancer survivors out there. But as there have become more childhood cancer survivors out there, we've also learned that they have unique medical needs. This is something that maybe 20 or 30 years ago, if you survived childhood cancer, oftentimes the physician or your parents or your peers would say, look, you've survived cancer. You don't have any other problems. You've really survived the big one, and you don't need to worry about medical complications. Surviving cancer is enough. But in fact, over time, we've recognized that childhood cancer survivors do have unique long-term medical needs. In my talk, I will make reference to something called late effects. And really, late effects are going to be any adverse medical or behavioral condition that occurs after cancer diagnosis, and that can be attributed to either the cancer or its treatment. And so there are several examples, just off the top of my head, something like secondary cancers, congestive heart failure, infertility, hypothyroidism. These are all would fall under the diagnosis of a late effect. Well, with regards to late effects, what causes a late effect, and how do you look at who is at risk of developing late effects? And it's not just a simple 1 + 1 = 2 kind of calculation, but rather it is multiple effects that all interrelate. And so, for example, there are issues that are unique to the patient that will put the child at risk of late effects. There are issues related to the child's treatment, as well as the cancer itself. All of these factors interrelate to put a child at risk of developing late effects. And so, for example, the child's age at diagnosis and interval since diagnosis will impact their risk of late effects. The child's gender, their socioeconomic factors will influence their risk of late effects, whether the child might have some pre-existing health conditions. There are also genetic risk and predispositions to developing cancer, as well as health behaviors that are unique to the patient, which would put the child at risk of developing late effects. With regards to the cancer itself, the tumor's location, whether it be a bone tumor located in the lower extremity, or a brain tumor, or a kidney tumor. The cancer-related morbidity, so for example, if the cancer causes a fracture in a bone, or if a cancer causes a bowel obstruction, that will influence their risk of late effects, as well as the response to therapy. And so tumors that have a very good response to treatment may need less therapy, whereas tumors that have a poor response to therapy may need more aggressive treatment. The treatment itself, whether it be surgery to remove the tumor, whether it be radiation therapy either to the whole body or to a specific region of the body, as well as chemotherapy and the specific agents that are part of the chemotherapy regimen will influence the subsequent risk of late effects. And then finally, the era of therapy. Treatment in 2012 is very different than treatment in, say, 1990, which is also very different than treatment in the 1970s. And so in some respects, for some cancers, treatment is becoming more intensive. In other diseases, cancer treatment is becoming less intensive. And so it's important to recognize that the era of treatment influences the risk of developing late effects. And so taking all of these factors together is going to impact the individual child's risk of developing late effects. So broadly speaking, chronic health conditions are relatively common among childhood cancer survivors. A study from 2006 looked at a large group of childhood cancer survivors and recognized that nearly 2/3 had at least some chronic health condition that could be attributed to the cancer. And 1/3 had a severe or life-threatening health condition. It was also recognized that there was an accumulation of late effects over time. And so that by the time the child was 30 years after diagnosis, and so these are children who hypothetically may have been 10 years at the age of their diagnosis of cancer, by the time they were 40, they had a 42% risk of having a severe health condition. The groups of cancer survivors that were at highest risk of developing late effects were those who were survivors of bone tumors, Hodgkin's disease, and brain tumors. The figure on the left is just a graph showing that the risk of late effects continues to grow over time. The table on the left looks at or lists a variety of the different late effects. They include things such as a major joint replacement as a consequence of having a bone tumor, congestive heart failure as a consequence of certain chemotherapies, secondary cancers, learning disabilities, stroke, kidney failure, hearing loss, and infertility. And so the point being is that there are a variety of specific late effects that affect young adults and among young adult cancer survivors. What were the risk factors for these health conditions? And you're going to see this throughout the rest of my talk as far as what these common risk factors are. Number one, it would be exposure to radiation therapy. And whether this is radiation therapy to the chest, the abdomen, or the pelvis, any of these regions increase the risk of developing late effects. Also, certain chemotherapy drugs. And among these chemotherapy drugs that put the child at risk of developing late effects included anthracyclines such as doxorubicin or daunorubicin, a chemotherapy drug called bleomycin that is used for Hodgkin's disease and germ cell tumors, and then finally alkylating agents which are used for a variety of different childhood cancers. Let me kind of pause here actually and remind you what I said at the beginning, that although I know this sounds scary and can certainly cause anxiety, this does not apply to every childhood cancer survivor. The development of late effects is really specific and unique to each survivor. So now I'd like to just give you some case presentations of patients that we have taken care of here at Children's Medical Center and UT Southwestern, and just tell some stories of cancer survivors and specific late effects that they developed. So for example, there was a 30-year-old woman who was treated for Hodgkin's disease. She was treated with mantle field radiation therapy, which is radiation to the chest, the armpits, and the neck, and when she was 14 years old. And now she's 30, and she reports that she has found a new lump in her breast. Well, the reason I bring this up is that we know that female survivors who were exposed to radiation therapy to the chest have an increased risk of breast cancer. Radiation treatment fields that increase the risk of breast cancer include radiation directly to the chest or a mantle field, as this patient received, but also radiation to the lung or spine will include the breast and will increase the risk of breast cancer. How high is the risk? It appears that the risk is about 20% of women who are treated with radiation therapy to the chest will develop breast cancer. The risk is higher among women who are less than 21 years of age compared to older women, and even in the more recent treatment protocols, we see an increased risk of developing breast cancer. When does this breast cancer develop? You start to see an increase about 8 years after radiation exposure. The median interval is about 16 years after radiation exposure. This means that a lot of these women are in their 30s, which is before the standard recommendations for breast cancer screening. Importantly, regarding prognosis of this secondary breast cancer, the 5-year prognosis correlates with the stage of the disease. So therefore it's important to catch this breast cancer early. It's also important to know that there may be some limitations in treatment because of previous cancer treatment. So what do? Well, we strongly encourage breast cancer screening. We encourage self-exams. We also encourage breast cancer screening, whether it be with mammography, ultrasound, or breast MRI. The Children's Oncology Group Late Effects Screening Committee has published guidelines regarding breast cancer screening. And to answer the question, when do you begin screening? We recommend screening once a year, beginning at age 25 years of age or 8 years after radiation exposure, whichever occurs last. And we believe that this recommendation will catch breast cancer at an earlier stage and will improve the outcome of women who have been exposed to chest radiation. Again, early screening is critical for the early diagnosis of these secondary breast cancers because the prognosis correlates with the stage. And so, for example, stage 1 or stage 2 breast cancer is usually very, very curable. And it's been found that it's very, very curable even among cancer survivors. So again, we strongly encourage screening. Well, despite our recommendations, how good of a job are we doing? In fact, half of women who should be screened are being screened. And this tells me that we need to do a better job of encouraging our women who've been treated with radiation therapy to go in for annual screening. And so this is my opportunity to say, if you're at risk, you need to be screened, and I'm really strongly encouraging you to have annual screening. The second patient is a 24-year-old woman who was treated for Ewingsarcoma when she was 8 years of age. And this woman is pregnant. Well, this woman goes to her OB-GYN, and she complains of fatigue and progressively worsening shortness of breath. And certainly, many women who are pregnant will complain of fatigue and shortness of breath. But this woman says, you know, this is not right. I really feel uncomfortable. Well, the reason I bring this up is because anthracycline chemotherapy, which includes doxorubicin, daunorubicin, and mitoxantrone, which is commonly used to treat many different childhood cancers, such as leukemia, lymphoma, bone tumors, such as Ewingsarcoma and neuroblastoma, can cause congestive heart failure and cardiomyopathy. Sometimes the cardiomyopathy is not present until decades after exposure. We also know that the cancer survivors have increased risk of a variety of different heart complications. It is dose dependent, and so people who are exposed to greater than 300 milligrams per meter squared cumulative dose have a higher risk than those treated with less. We know that the longer you follow patients who've been exposed to doxorubicin or daunorubicin chemotherapy, the rates continue to increase. Females have higher risk than males. Younger children have higher risk than older children. And then also, certain children who receive radiation therapy to the heart, in addition to doxorubicin or daunorubicin chemotherapy, also have higher risk of cardiomyopathy and congestive heart failure. So why is this important for this woman? There have been many reports of sudden onset congestive heart failure among pregnant women in the later stages of pregnancy or during the at the end of pregnancy before the child is born. And this is, as a result, we consider women who've been treated with anthracycline chemotherapy to have high-risk pregnancies. And we encourage those women to be followed by a high-risk pregnancy program during pregnancy. One report that is probably the one that's cited most often described a 30% rate of congestive heart failure among women treated with anthracyclines who are pregnant. The Children's Oncology Group Late Effect Screening Committee has come up with guidelines for screening for cardiomyopathy and congestive heart failure. And so I print them here, but basically these are guidelines that are dependent upon the child's age at exposure, whether or not they receive radiation therapy to a field that includes the heart, as well as the anthracycline dose, and how often the child should be screened for cardiomyopathy. And this is something that the ACE program follows as far as how often we screen our patients by echocardiogram or cardiac MRI for congestive heart failure or cardiomyopathy. The next patient is a 28-year-old man who was treated for acute lymphoblastic leukemia when he was 4 years of age. Part of his treatment included cranial radiation therapy, which is sometimes done to prevent relapse of CNS leukemia. And this young man has obesity, dyslipidemia, or high levels of lipids, and high blood pressure. It's recognized that childhood leukemia survivors have increased rates of obesity, elevated cholesterol, elevated LDL cholesterol, which is the bad kind of cholesterol, as well as high triglycerides and higher rates of diabetes or insulin resistance. And the combination of obesity, abnormal lipid levels, insulin resistance, and high blood pressure is referred to as the metabolic syndrome. And we know that the metabolic syndrome places adults at very high risk of developing cardiovascular disease, which puts them at risk of developing myocardial infarction and stroke. And these are complications that are relatively common among older adults, but we are beginning to see these complications in our young adult survivors of childhood cancer. We also recognize that there are other conditions that potentially could make this worse, such as physical inactivity, such as hormonal imbalance and genetic risk, as well as the progressive aging of the child. And so we strongly encourage physical activity and weight loss and treatment of diabetes or prediabetes among our cancer survivors. So what do the long-term follow-up guidelines recommend? Well, we recommend screening every 2 years with a blood glucose level to screen for diabetes, as well as lipid profile to screen for abnormal lipid levels. We know that there are high-risk populations, which are those that have been exposed to radiation therapy to the brain. We closely monitor weight over time among our survivors. We encourage healthy diets. We also encourage physical activity. And for those patients who have elevated lipid levels, we treat these young adults who have high lipid levels because we believe that if we can treat these complications early, we can prevent cardiac damage and we can reduce the risk of myocardial infarction. And then the last patient is a 25-year-old man who was treated for medulloblastoma when he was 5 years of age. This young man has some cognitive impairment. He also has obesity, and he comes in to see us with new onset left-sided weakness. Well, what's going on with this patient? Well, first of all, with regards to his cognitive impairment, we know that children who are exposed to cranial radiation sometimes have learning disabilities. So among these learning disabilities include disorders of attention, problems with short-term memory, slow processing speed, and impaired working memory. And working memory refers to the ability to organize complex tasks and to come up with a plan that includes multiple sequential steps. We know that there are certain high-risk populations at risk of learning disabilities, which include young children, especially those less than 6 years of age. Females seem to have higher risk, and then also brain tumor survivors who have a history of hydrocephalus also have higher risk of learning disabilities. Well, what do we do for these children? We try to get them hooked up with tutoring, with special education services, as well as other accommodations at school. But nonetheless, we recognize that these children often struggle as they enter into adulthood. But what about the new onset neurological symptoms that this child has? We know that brain tumor survivors who are treated with cranial radiation have increased risks of stroke and secondary cancers. Now, let me step back and again say, just because there's a risk does not mean that every child who's been exposed to cranial radiation is going to develop a stroke or have a secondary cancer. We know that the patients who are at the highest risk of developing strokes are those who've had a brain tumor, those who've had leukemia treated with cranial radiation, as well as those who've had Hodgkin's disease, which includes radiation therapy to the neck. This is a graph that shows the risk of developing a stroke over time. Let me emphasize that the y-axis on this graph goes up to 10%. This is not 100%. And the x-axis goes out to 30 years. So basically trying to demonstrate that 30 years after diagnosis and long-term remission of the child's cancer, there's about a 10% risk of having a stroke. Now, this also means that there's a 90% risk of not having a stroke. And so, again, I want you to kind of take away that these are rare events, but it is something that is a possibility. Also, the other thing that is a possibility is developing secondary cancers. And just as women who've been treated with radiation therapy to the chest have an increased risk of developing breast cancer, patients who've been exposed to radiation therapy to the brain have an increased risk of developing secondary brain tumors. We know that there are certain genetic predispositions, such as a syndrome called neurofibromatosis and Lee-Fraumeni, that increase the risk of developing secondary brain tumors. There are two main types of brain tumors that these children are at risk of. There are high-grade gliomas that occur in the first 15 years after exposure to radiation. And then there's another type of tumor called a meningioma that can occur 20 years, sometimes even 30 years after exposure to radiation. It's important to recognize that especially children with meningiomas have a very good prognosis. Even, these are tumors that may develop 20 years after radiation exposure, but oftentimes these children can be completely cured with an operation to remove the meningioma. This graph here demonstrates the cumulative incidence of secondary brain tumors and secondary cancers among childhood cancer survivors. And so again, let me demonstrate that here on the y-axis it only goes up to about 10%, but the risk of developing meningiomas, which is this red line here, is about 3.5% at 25 years after diagnosis of the primary brain tumor. So again, I'm not putting this up here to scare you because the risk is about 3.5%, which means there's a 96.5% likelihood that this would not happen. But again, I want you to be informed to know that this risk exists, and so that if you do develop new symptoms, that you would seek medical attention to try to get these issues taken care of. So what about fertility after cancer treatment? And I think this is one issue that that families ask most often about. So importantly, many childhood cancer survivors are able to have children. Infertility and reproductive dysfunction are common among certain subpopulations of survivors, but not all survivors. Among the groups that are at highest risk of having problems with fertility would be those who've been exposed to alkylating agent chemotherapy. And I've listed the alkylating agents that are most commonly used for treatment of children with cancer here, but among them include cyclophosphamide, ifosfamide, busulfan, procarbazine, melphalan, and cisplatin. Also, people who've been treated with radiation therapy to the pelvis or reproductive organs also have higher rates of infertility. It's important to know that at least sometimes patients who've been told that they are infertile will have recovery of fertility years after being told that they were infertile. And so just because somebody may be told that they were infertile when they were 20 years old does not necessarily mean that they're still infertile when they're 30 years old. And then finally, the other thing that I think is important is to remember that there are other chemotherapy drugs that are commonly used for treating children with cancer, such as methotrexate, 6-mercaptopurine, cytarabine, and several others, which in fact have no effect on fertility or reproductive function. Let's see. What about women who've been treated with radiation therapy to the pelvis? We know that women who've been who've been exposed to radiation therapy to the pelvis have higher rates of premature menopause. They have increased risk of complications during pregnancy. They have higher rates of preterm labor, and also their infants, at least sometimes, have lower birth weights. One thing that is good news, however, is that the rates of congenital malformations and birth defects, in fact, is no higher among cancer survivors than the general population. So therefore, cancer survivors do not have higher rates of birth defects than the general population. And maybe the only exception to this would be that there are certain cancer survivors who may have a genetic predisposition to developing cancer, such as neurofibromatosis or Li-Fraumeni syndrome, and their children, as would be expected, will still have the potential of inheriting that from their parents. So with the understanding that there's one exception, oftentimes children who are the offspring of childhood cancer survivors are healthy and have no higher rates than the general population. Again, fertility and reproductive functioning after cancer treatment. It's important to monitor puberty and sexual functioning after cancer treatment. And there are several sources of useful information for fertility. Among them would be the American Society for Reproductive Medicine, and I listed their website there, as well as an organization called Fertile Hope, which is connected with the Lance Armstrong Foundation. And both of these websites have useful information regarding infertility among cancer survivors. What are the other implications regarding issues with fertility and reproductive functioning? We know that the sex hormones have an important role in pushing calcium into the bones, and so therefore sometimes women who have low estrogen levels will have decreased bone density decreased bone density and will be at increased risk of fractures. And so therefore it's important to screen people who've been exposed to alkylating agent chemotherapy for the possibility of impaired or reduced hormone levels, and that those women would benefit from hormone replacement to make their bones stronger. And then finally, this last comment just being that because there is a risk of premature menopause, we do counsel women that they may want to consider this and consider having children earlier because they're at risk of premature menopause. And then in the few minutes we have remaining, I'd like to talk about some of the other complications and interventions that we recommend for adolescent and young adult survivors of cancer. So what about lung complications? We know that cancer survivors, especially those who have cancer involving the chest wall or the lung, will have some certain lung complications. Among these include abnormal chest wall movement. They're at risk of lung fibrosis or chronic pneumonias. Factors that increase these risks include radiation therapy to the lung, as may be necessary for certain survivors who have had metastatic nodules in the lung. There are certain chemotherapy drugs such as bleomycin, again used for Hodgkin's disease or germ cell tumors, busulfan that's used as part of bone marrow transplant, and CCNU, which is an alkylating agent, that increase the risk of developing lung complications. Smoking also increases lung complications, and my next slide talks a little bit more about smoking. But if you're a cancer survivor and you smoke, I strongly encourage you to consider stopping smoking. Also, patients who've been treated with bone marrow transplant and those who are younger at time of diagnosis of the cancer have increased risk of lung complications. So what about smoking among cancer survivors? This table here looks at rates of smoking among cancer survivors compared to the general population, as well as are you recently smoking or have you smoked in the past 6 months. And in fact, rates of smoking among cancer survivors is equivalent to that in the general population. And these statistics kind of boggle my mind a little bit, because you'd think that if anybody would be aware of the reality of having a diagnosis of cancer, you'd think that it would be cancer survivors. But in fact, cancer survivors do have higher than expected rates of smoking, and they're equivalent to the general population. The presence of smoking is associated with a variety of other complications and poor health risk or poor health behavior decisions. And we strongly encourage smoking cessation, and we try to target the cancer survivor as well as their family and peers, because you need a support system if you're going to try to quit smoking. And again, we know that smoking increases the risk of complications after cancer, and we strongly encourage our cancer survivors to stop smoking. What about decreased bone mineral density or decreased calcium in your bones? The consequences of decreased bone mineral density includes an increased risk of osteoporosis and an increased risk of fracture. The risk factors for developing low bone mineral density include a prior diagnosis of leukemia, decreased activity or immobilization, be it at bed rest for a long time, malnutrition, which sometimes occurs during cancer treatment, and treatment with certain chemotherapy drugs, including steroids, methotrexate, and cyclophosphamide, as well as radiation exposure to the reproductive organs, the brain, or total body irradiation. What do we do for our cancer survivors who are at risk of developing decreased bone mineral density? First, we encourage increased calcium consumption. We encourage vitamin D intake with a supplemental vitamin. If the patient is found to be low in estrogen or testosterone, we encourage replacement of those hormones. We strongly encourage exercise and physical activity. Arguably, I think everybody should increase their exercise and physical activity, and perhaps try to make this as a family goal to exercise together. And then finally, smoking, alcohol consumption, and caffeine consumption all are associated with decreased bone mineral density. So we try to discourage these things as well. So let's kind of come back full circle. This is a figure that I showed at the beginning of my talk, showing all of the different factors which have a role in developing medical complications after cancer treatment. And we can impact these at various different levels. And so, for example, with regards to the cancer, I think we now have improving diagnostic tools which allow us to diagnose the cancer at an earlier age and at an earlier stage, and potentially modify treatment in a way that would reduce the risk of late effects. We also have defined risk-based populations. Therefore, some patients may need less therapy and other patients may need more therapy, but understanding the cancer better will impact the rates of late effects. We strongly encourage stopping smoking. I think I've said that a few times this morning. We encourage exercise. Again, I've said that a few times this morning. And reduce obesity, because we know that that will reduce medical complications after cancer. There are new chemotherapy agents which may allow us to eliminate or at least reduce the dose of radiation therapy and alkylating agent chemotherapy. These may reduce the rates of late effects. We're trying to reduce the rates or reduce the radiation exposure among our cancer survivors, as well as, in certain circumstances, offer chemoprotectants to reduce the rates of late effects. And then what else can we do? Well, I think rehabilitation is also important. So we encourage physical therapy or cognitive therapy or other therapies to try to reduce the severity of the late effects. And then finally, I believe that screening for late effects also has an important role. And screening for late effects is something that happens with our ACE program medical evaluations. So what do we do as part of our ACE program cancer follow-up evaluations? Number one, we monitor for recurrence of the cancer, although that is very rare among patients who are followed in the ACE program. We provide surveillance for secondary cancers and late effects, such as mammography or breast MRI, because we know that early diagnosis and intervention will reduce the severity of the, or will improve the prognosis of the secondary cancer. We also promote cancer prevention and good, healthy lifestyles. And among these things that we encourage are to stop smoking, increase your physical activity. We encourage you to eat a healthy diet. And I know that one of the breakout sessions this afternoon is going to be focusing on eating a healthy diet. And then we also encourage increase in calcium intake and vitamin D consumption, because that will build healthy bones. And then also we provide education about the cancer and its treatment. And one thing that we find among our young adult survivors of childhood cancer, especially those who may have been treated when they were young children, that they really don't remember a lot about their cancer experience. And it's important that they know about their cancer experience, because as these young adults grow up, leave the house, go to college, oftentimes move far away from home, they will be responsible for taking their own medical history with them as they transition to other stages of their life. And it's important that, say, for example, if somebody's in their 30s who may have had childhood cancer when they were very young, that they know that they had acute lymphoblastic leukemia, that they know they were treated with anthracycline chemotherapy, that they know what their potential risk factors for complications are. And so therefore, one of the most important things that we do in the ACE program is to provide education about the child's cancer and its treatment. Also, with regards to screening, the Children's Oncology Group Late Effect Screening Committee has a website, which is www.survivorshipguidelines.org. And this website provides screening, or provides the screening guidelines as well as the evidence behind these screening guidelines for our cancer survivors. And anybody can access this. You don't need a password. And it will provide what the current most up-to-date screening guidelines are, as well as the evidence that supports these screening guidelines, and identifies who the high-risk populations are. And so when you go to this website, this is the screen that is that will show up. And again, the point being is that this is version 3.0, which is currently 4 years old, but these guidelines are being continually updated every year, and the current version of the guidelines really has very, very up-to-date guidelines. And so if you're interested in learning more, I encourage you to go to the Children's Oncology Group Survivorship Guidelines webpage to find this out yourself.